are planning to give chemo, we are planning to do, if it's possible, we are planning to do radiation. But what else are we not doing? A lot of the times as medical practitioners, because we are training to be medical practitioners, we just think pharmacotherapy. We actually think biomedical interventions. We forget to incorporate the psychosocial aspect, the emotional, the spiritual needs around palliative care, and which is actually a very powerful way in which we have a holistic approach to our patients. WHO defines palliative care as an approach that does the following. I'm going to copy paste some of these factors on the chart. One, it affirms life and regards death as a normal process. Do you think death is a normal process? Is death a normal process? Somebody can unmute and talk. Is death a normal process?
Definitely.
Kelly is saying definitely. Kelly, quantify.
Everyone dies, whether we think it as a normal process or not. It will catch up.
People will die. So maybe I should have rephrased. Is it easy to accept death? Kelly, is it easy to accept death?
No, not at all.
Nobody says no, it's not. It's not easy to accept death. So do you think we also need to medicalize acceptance of death? Medicalization is just basically we integrate death as part of our training. I know we have in different ways. A patient will either live or die. But an intentionality around speaking about death. Who among you has been trained around an intentionality around death? We've all been trained around an intentionality around preventive, curative, rehabilitative. And the last one on that spectrum, death, has not been something that we have thought about to be able to be taught. So a lot of the times, I don't know when your first death occurred. My first death was a finalist. I was in Kenyatta National Hospital. A patient had been referred from the periphery, came in with severe anemia. That was like a 14-year-old boy who had previously been stable, just started a sudden onset of difficulty in breathing, and collapsed. So very fast, periphery, very fast, paper whites. They say just severe anemia, referred to Kenyatta. By the time we're taking blood to the labs, the boy coded. And he was coding as I was actually bleeding him the second time, because I'd removed my first pipette. It's called a Vacutainer, rather, my first Vacutainer, then I was taking the second one. Then he coded and he died. Nobody had prepared me for that time. Because I remember I had just asked the dad to step out and to allow me to be able to speak to the patients because they could be coherent. And then I needed also to do some biomedical, what are they called? Procedures. I needed to catheterize because we also needed to measure the input output for the urine. I needed to get more blood. So a little privacy. So the dad steps out. No sooner had he stepped out, then the boy coded. I didn't know what to do. I just went directly to doing CPR. And I remember thinking to myself, I remember stopping my CPR and going to call the registrar, who was quote unquote my supervisor as a finalist. And then he certified that. He just looked at the boy and said, Dr. Stella, this boy is dead. I was like, no. I was speaking to this boy a few minutes ago. He said, Stella, this boy is dead. So as I'm coming out, the dad is saying, sasa mumeweka mpira, mumetoa damu, let me go in and talk to him. And then casualty, I look at this old man and I start saying, I'm sorry. And the old man breaks down and says, I walked in with my son to Kenyatta National Hospital speaking to me. What's up with my son? And I told him, I'm sorry, we have lost your son. And for me, the burden of that loss was so heavy. The burden of the loss was beyond just me. The guys, just give me a